another Sagely Health webinar. My name is Jeremy. I'm the CTO of Sagely Health, and I'm joined with the founder and CEO of Sagely Health, Dr. Jason Sager. Jason, how are you?
Great, Jeremy. Thanks so much. Happy to see everyone.
Yeah, thank you for joining us, everyone, today. We'll get right into it, but our topic for today is choosing an oncologist or a cancer surgeon. Cancer is very complex, and for everyone, it's kind of a different kind of path for different people. But the one common thing for everyone is you are going to see an oncologist, and in some cases, you will see a surgeon. So this is kind of one of the bigger decisions that gets made, and I think it gets made relatively quickly, and I don't think people put a lot of thought into it. And sometimes they end up having to. But so let's just get into kind of that choice of a doctor. And so it always starts with a diagnosis. So Jason, I would want to just talk a little bit about kind of the different situations in which people find themselves diagnosed. I know that some people will have symptoms and that'll take them to their primary care doctor. Some will have an incidental finding, something else, and sometimes an emergency situation. So I'd just love to hear you talk a little bit about those situations and kind of how oncologists get assigned, or you find an oncologist in those situations.
Yeah. And Jeremy, it's something that, cancer is so chaotic, right? And people, when they hear the word cancer, oftentimes, kind of like, the alarm bells go off. And, keeping, trying to understand, okay, who is it that I need to see and how am I going to get this information? Most patients get the diagnosis through some sort of a biopsy or a piece of tissue that's being removed from what they think is a tumor. And maybe it turns out not to be, or it turns out to be. And oftentimes that's sort of arranged for by either, let's say, the primary care doctor, or if because of pain or other issues they're in the hospital, it'll be arranged for by the hospital. But really, until that comes back, that's when a cancer surgeon or a cancer oncologist really gets involved, kind of steps in the room. And so it's important because, once the diagnosis is made, either in the primary care physician's office or in the hospital, it's oftentimes the doctor who's then activating someone in their system who would be assigned to the patient as their treating cancer doctor. And I use that word to kind of create an umbrella over the surgeon, the oncologist, and then even the radiation therapist, right? The expert for radiation, all of which can be used in treating cancer. And so, and it won't necessarily be all three. And I know we've spoken about in previous episodes where we talked about making sure you ask for an opinion from all three, or when that's appropriate. But in addition to that, I'd say most cancer patients are not aware that there is a decision or a choice to be made in choosing a physician. And the answer is yes. Now, there may be some nuances to this. If you're in the hospital and you can't really get out of the hospital, then you start with the folks that you've been assigned to, or that you've been introduced to. There's no downside to doing that. But I just want to make sure that folks leave our webinar today knowing that that's not where it should end, right? And then in specific cases, and that's where we can get into some of the nuances today, when would a patient ask for more, seeing another doctor or a specific cancer surgeon as opposed to a general surgeon, or someone who's had 20 or 30 years of experience versus a couple, or someone who's running a clinical trial versus someone who's not. And so those are some of the things that we'll talk about today.
Can we talk a little bit about urgency? Just because I think that that's something I've seen is, the diagnosis happens, the biopsy comes back, pathology comes back, and it's cancer. And so then, someone suddenly finds themselves sitting across from an oncologist or sitting across from a surgeon, and I think they're being offered treatment right away. And so I just want to kind of say, like, should people be pausing in that moment? Should they be urgent to get that, whatever treatment's offered to them? I want to just kind of hear a little bit from you on that.
Yeah, I'd say the vast majority of situations are not urgent or emergent, like an emergency. Now, there are a couple. And what I'd say is use, that they should seem to be fairly obvious to patients, with maybe one or two exceptions, and we can talk about it. The most obvious thing is like if the tumor, the cancer, is blocking the function of an organ that you need to live, which most of your organs you do, then that can be an emergency. So a few examples of that is a tumor which is a colon tumor which has grown and is now creating an obstruction in the colon. It's almost like it doesn't really matter if it's spread or not. They just need to get that tumor out of the colon so that the colon can pass through all that it does and you can keep on living a normal or a life. The liver, I'd say, is another example where, again, the tumor can actually squeeze close some of what they call the bile ducts, some of the normal drainage of the liver. And, obviously, if that gets backed up, it doesn't work well. And so those are examples where a stent may need to be placed that kind of pops open that duct and kind of keeps things open so that then treatment can begin. And then, we can start to, but all of the other stuff is all stuff that there is time to work on it. I know, and here their system sometimes utilizes that sense of urgency in a way that I would say is a little inappropriate in that they may say, well, like you're not metastatic today, but we better go and get this out today because tomorrow you could be metastatic. That's possible, but I've never seen it in 20 to 30 years. So in the sense that, much more commonly, it is what it is. It's either has spread or it hasn't spread, and you have time. Now, not years, but you got weeks, maybe even a couple of months, depending upon the cancer type. Now, there's some rare exceptions. The one rare exception we always talk about is a type of lymphoma called Burkitt's lymphoma, and they're usually in children. They come in with a big abdomen, and if you don't treat on a Friday, they may not be there on a Monday. That being said, the treatment is really effective, and so that's the other piece of this is if there is an effective treatment that's going to lead to a cure, that's when patients can kind of go along with the system. If there's a cancer type like pancreatic cancer, or if it's spread and they find out on a CT scan or a scan that it's spread, that this is a high risk situation, there's more of an importance to find the right path forward and make sure that that's the very best path at each of the steps of the way. And that's what we're here to help guide patients to do. So that's sort of what we encourage them to do.
So, there's surgeries that might be kind of there to deal with an emergent issue affecting an organ, and it kind of has less to do with treating the cancer than just kind of treating the function of that organ.
Yes.
Then there's kind of this big kind of fork in the road for patients, where is surgery an option, meaning curative surgery. We like surgery with the hopes of removing the cancer completely. And so in that case, you're probably going to meet a surgeon, and that surgeon is going to give you some type of instruction on what they expect to do and what they expect the results to be. So, you've talked a little bit about there might be less urgency of kind of hear that surgeon out, but, may say, hey, okay, well, thank you so much. Like, I'll get back to you, if it's not like not urgent,
Right.
they got nurses and people standing around you. So let's talk a little bit about how, if someone was to take a pause at that point, I'd love to hear a little bit of like, what does a successful surgery look like, and who should I be going to have that successful surgery?
Absolutely. And it is really important. It's actually, to me, it's much more important than, doing it rapidly, as long as there's not an organ obstruction taking place. And
Right.
then you just got to go with it. And then you may actually do a second surgery later or take another look or whatever it is with someone who's expert. But you can kind of see where we're going, which is, what you want is the right surgery to be done as much as possible the first time around. And even some of these surgeries are quite difficult. Even breast cancer, even the best cancer surgeons in the world have to go back about 1 in every 5 patients to do a little bit more. But what you're looking for is to be able to remove the entirety of a cancer. Usually, if you're in the surgeon's office, it's a local cancer. It hasn't spread, and so, or maybe it's spread regionally, but it's still important to take out the sort of the mother load of it. And so you're really wanting to get around the tumor in such a way that you have what's called negative margins. And I think most people have heard that term before, but basically it's a rim of normal tissue that comes out with the tumor. In order to do this, the expertise of the surgeon matters, and the experience, right? And so, from my perspective, how are they going to go in to try to get around this tumor without really disrupting it? You don't want those cells kind of floating about. But then also, right, can they get that margin? And then, do they have the experience, right? And we're not talking about like even 2 or 3 years. We're talking like 10 or 15, 20 years of experience in doing this, and how frequently they do it. And so one of the adages that we tell patients is, go to an NCI accredited cancer center. And there, again, you can ask the surgeon, how many years of experience do you have? Or what's your what's your complication rate? But you kind of don't have to, because those NCI accredited cancer centers are nationally sort of approved, and so they have the volume. That they're going to be seeing, every week, multiple cancer patients just like you, in order to get this surgery done, and that's really what you want. So that's one of the sort of the cheats that we recommend to patients. If for nothing else, go to an NCI accredited cancer center if you can, and there's a map of them, and we're happy to help patients find them and get introduced to the right doctors.
So not having those negative margins, as you say, means that there are still cancer cells that are existing in that tissue. And then the likelihood of that kind of returning and spreading is high. And so I just want to kind of point out that when you meet with a cancer surgeon and you have a surgery, if your cancer comes back, it's usually not that surgeon's problem anymore. You're now probably going to end up in a radiation oncologist. So they've got a very set goal that they have, which is how much can I get this tumor out completely, and they're kind of doing the best they can, but that's their role. So
Right. Actually, I just one correction. More
yeah.
the medical oncologist. If it comes back, it's likely it may come back in the same area, but it's more likely to have spread somewhat. And once it spreads, it's really in the medical oncologist, because they're treating with systemic therapies. They may be chemotherapies, they may be targeted or immunotherapy, but it's sort of trying to deliver it across the whole body, because the cells have escaped. They've kind of gotten around, and they've spread. And so it's important. That's radiation oncologists do come in and play an important part. One of the things that radiation oncologists can do is, if there are positive margins, radiate that area. And this is very common in breast cancer, again, where they'll do a lumpectomy, but then they'll radiate anyway, because even if they get good margins, there's still the possibility that a couple of cells have gotten loose. And so radiating it afterwards in that same area can really kind of seal the deal, so that it doesn't come back, and lower the risk. And so there's all sorts of approaches. And that's why it's important to have sort of a holistic approach to cancer treatment, including the surgeon, the medical oncologist, and the radiation oncologist.
So I think many patients are not going to understand that nuance in the chaos of the moment, right? So you're meeting with a surgeon, and they're saying it's operable, good news. And so what questions should someone kind of be armed with at that point? If they got the surgeon sitting in front of them, what should they be asking that surgeon to get the best information, the best treatment?
Yep. And so one is, if it's a surgeon who their primary care doctor, first of all, are you a cancer surgeon? How many cancers, how many cancers like I have do you work on a monthly basis? And if they say a couple, really what you want to ask is, how many do you work on a weekly basis, and have it
Right.
be like 5 or 6 or 10, right? But if you ask on a monthly basis and the answer is 2, then you know that they're not seeing many on a weekly basis. So that's one sort of avenue to pursue. And then you could, and again, you'll know, or you can ask, is this an NCI accredited cancer center, or could you recommend one to me, and see what they have to say. I'd say the second part to ask them, and this really doesn't matter which doctor is in front of you, is to say, is there a role for treatment before the surgery to make the surgery more successful? And that's something that is called, technically, it's called neoadjuvant treatment, or after surgery to make the surgery more successful, in the hopes that the cancer won't come back. And that's we call adjuvant therapy. And that can be, again, a type of systemic therapy. It could be radiation therapy. It could be a combination of the two, either before or after the surgery. that really helps to pave the road, because sometimes you can give it before the surgery and the tumor shrinks, easier for the surgeon to get the tumor out and have those clean margins. On the other hand, as we talked about with breast cancer, you do the lumpectomy, and then afterwards you want to do that radiation to kind of seal the deal so that you have the lower risk. And that's really, I think those are the questions, primary questions that I like patients to ask their doctors when they're considering surgery for cancer.
That's great. So we're talking about going to NCI accredited cancer center. Should you get a second opinion for surgery? Like if you are at an NCI accredited cancer center, like, and if you go somewhere else to get a second opinion on surgery, what might be different
Yeah.
between one place versus the other?
It's a great question, and from my perspective, it really does involve the question of risk, and whether or not the cancer is a high risk cancer, meaning it's likely to come back. We say anything that has more than a 20% chance of coming back is a high risk cancer, but we're pretty, we really want to do our best with our patients. On the other hand, it could be a low risk cancer where there's less than a 20% chance or maybe a 2% chance of the thing coming back. But okay, the world has figured out how to do this. For example, that the breast cancer, stage 1 breast cancer, great. But when you do see some conflicting information, and even if it's a low grade tumor, maybe a DCIS in breast cancer, but maybe there's several locations. Maybe it's on both sides of the breast. So what's the right treatment? It never really hurts to get a second opinion. Again, yes, there's urgency, but it's not with a capital U. Don't wait years. Don't wait even months. But you could wait a couple of weeks to get another appointment and see another either cancer surgeon or oncologist. And I think those are the patients who are proactive in that way that come out with generally the best results. If you see both and they say, no, like if the treatment's the same, and you're going to do well, just go back and do it. Great. No problem. But more likely, you're going to hear some of the nuances. Yeah, like I might do it with this approach. I might have a mastectomy and not a lumpectomy, even though it's probably okay. And maybe I would use radiation, or maybe I would do some chemo, or you're at the age, or let's go and do a oncotype test. I mean, there's a lot. It's so complex. Cancer is so complex. And rather than, trying to navigate that, that's why we try to give patients those key sort of questions to ask. How what is the risk of my cancer coming back, doctor? Right? And if they say, if they kind of look down or do something, oh, don't worry about that. Well, what's the percentage? And Google will give it to you, and we will too, along with the instruction set of what to do with that, so that you're not left reeling and in that world of chaos, but really have a plan for how to approach this in order to lower that risk. That's our goal.
That's a good way to segue into kind of what I'd call higher risk, which is people who surgery is not an option. It's either when they were diagnosed, there was already spread, so they would need a systematic treatment, or they've had a surgery, but there has been a return, so they find themselves with advanced or metastatic cancer. And so in that case, surgeons probably not going to be in the room anymore. And so in that case, how do you think about choosing a doctor in that situation as opposed to surgery?
Yeah. And first of all, like, it's one of the things that it's another question we have patients ask, whomever their doctor is. Do I need to get a scan of my body to look to see if the cancer has spread? Now, most of the time in the US, patients are getting this, but we know examples where they haven't, or outside of the US where they haven't. And it's really important because the surgeons may say, well, I can take out this cancer. And then they come out and they say, we got all the cancer out that we could see. Well, great. Does that mean that they got all the cancer out that is there? And did we look to see if there was any there beforehand that may have spread? Because you're right that, there may be still a reason to take out that primary tumor, the original location, largely because it could block an organ in the future. But there are times where you would then not do that. And we have a couple of prostate cancer patients who right now are going through radiation, not surgery, of the primary tumor, as well as some lymph nodes and other bony metastases that are around, such that control can be gained across the board. And really at that point, it's about really, again, extending life for a very long time. And we're talking about decades is the goal. Some cancer types are more amenable to that. Some cancer types are less amenable to that. But really, that's where the question of what's the best approach is. And from our perspective, again, experience matters. The National Cancer Institute accredited cancer centers matter. But then beyond that, having doctors who are at their fingertips have the most advanced treatments possible and the most advanced diagnostics possible, tumor sequencing, proteomics, RNA sequencing on the diagnostic side. And on the treatment side, it can be antibody drug conjugates, it can be other targeted therapies, selective therapies, immunotherapy, not just chemotherapy. Those are the things that to me matter most, because what it means is if you find those doctors or a doctor at a time that does that, and you may need to go to several, we'll talk about that in a minute, but if you do that, again, you have the best chance of coming out the other side with the best outcome possible, and that's our goal.
Yeah, so there are guidelines for treatment that are produced by the NCCN and by different cancer types, and most oncologists will use these guidelines to understand treatment in different scenarios. And these guides are great; they give a standard for which people are treated. So what we're talking about is when you talk about a doctor or something else at their fingertips, those are doctors who are involved in clinical research, meaning trying to kind of improve upon the existing standards. So one of the reasons you're saying they're the ones to talk to is because they have the standards, they understand the guidelines, and they could offer you those, and they may offer you those. Those might be the best match for you, but they just have other things that are being pursued that might be a good fit for you. Is that kind of how I should understand that?
Absolutely. And again, those can be clinical trials. Those can be familiarity with drugs that have been in clinical trials that they're then comfortable using outside of trials. There's a number of different possibilities. But yes, all doctors will know and will have the standard of care. And again, some of the standards of care can be quite good. And that would make it low risk. But in the cases that we know that it's not going to, or highly suspect that it won't, then winding up with one of these doctors, oncologist, medical oncologist, in coordination with, right, whether or not surgery is appropriate or not, whether or not radiation is appropriate, but an oncologist, medical oncologist, who really can have multiple options at their fingertips to use in the best way possible for you. That's what to me matters most.
Yeah, I would say just having talked to as many patients over the years that a lot of an oncologist might say to you, "We have a treatment for you," and they want to ease your mind. They want to say, "This is treatable. We have a treatment for you." And I don't think that you should hear that as "We have a cure for you," or "We have like a high likelihood of a cure for you," or so. But that may be true depending on what the treatment in your situation is. But that's something where I see too many people go and they go Google it on the side as opposed to having that conversation with their oncologist and saying, "Okay, if we're doing that treatment that you're recommending, what do I expect to get out of that treatment? How many patients respond, how many patients respond for how long, and do they have to have other treatments after that?" And I think there's not a lot of interrogation going on because of some of the chaos, right? I've got a treatment for you, and here it is. And we're saying there may be a lack of there may be not so much urgency that you couldn't stop and say, well, let's talk about other treatments or let's explore other things. So
Right.
so I think that you know, what are the hallmarks that someone should really get a second opinion? I want to kind of ask you that. Should all cancer patients get a second opinion? Should certain ones?
Yeah. Yeah. From my perspective, if the cancer is high risk, then the answer is yes. And you just, again, if at worst you don't hear anything new or different, but it's also important where you get that second opinion from. And what we'll do at Sagely Health is we'll take a look at what the options are. We may not be able to find out all the information about all of the different options, but we'll know who has those options, and we'll pick a doctor or more, two maybe. It's usually two doctors that we'll send a patient to ask to put a list of those treatments that we know that doctor has in front of them and say, you know, are any of these reasonable to consider? And with the answer being an obvious yes. And if so, do you have a favorite? And again, we may know about published information in one and may not be published information in another, but the doctor knows how well it's working. And
Yeah.
so allow them to have some sort of guidance as well. And that's really kind of the way that we kind of work and do things.
So I want to ask about a particular situation, which is when someone faces a recurrence or progression. So you have an oncologist, you're getting treatment, and maybe that treatment works for a time, but then it stops working. And so at these points, I mean, I can imagine that some patients would be very scared to get a second opinion at that point, kind of feeling like they're going away from the oncologist, but also maybe feeling like they should at that point. So I'm curious, how do you like when people are at those kind of those decision points of like facing a recurrence? Is that a time to get a second opinion? Is that a time to hold fast to where you are? How do you kind of understand that?
Yeah, I think that using the recurrence. So first of all, it doesn't happen usually in one day. It might. More often, you'll start to see signs. The
Yeah.
PSA may start to go up. The tumor may start to grow. The chemotherapy or the systemic therapy is still working. The standard of care may still be working, and it may be slowing down the rate of growth of that tumor. So don't stop. But that's the point where you say, okay, it's time to line up the next sort of set of possibilities. And that's where getting a second opinion and getting it from someone who has something novel, innovative, and something personalized to your tumor for you can make a huge difference.
So there are clinical trials for almost every type of situation, even early stage. There's across the board. I don't think we've ever had a patient and we haven't been able to identify one clinical trial that fits them. But more commonly, clinical trials will say, "Well, go through the standard treatments first." Or some version of that. And so those moments of recurrence are kind of those moments where you've had a treatment and maybe it might be time to consider a clinical trial at that point, because with a recurrence your risk has definitely gone up. You're probably entering that area of high risk, as we've talked about. So kind of that's a good time to find a doctor who's involved in clinical trials, because they might say, no, there's another round of standard treatments that we think is a good match for you and worth doing. Or they might say, no, it's time to actually jump to this. Is that kind of a way to understand why to see these particular doctors?
Yeah, absolutely. Absolutely. And I want to bring up something that we haven't talked about, which a lot of patients ask about, which is the personality of the doctor,
Oh, sure, yeah.
especially with the surgeon, but then also with medical oncologists and radiation oncologists as well. How much does confidence matter? And it's interesting because I do think that personality matters. It's important to be able to converse with the doctor, ask them questions, and not feel like they're making you feel uncomfortable to ask those questions. Make sure that when they give you an answer, they're giving you a straight answer. It may not be one that you want to hear. Most cancer patients, and I've known a few breast cancer patients who have switched surgeons because they told them there's a 20% chance they'll have to go back to surgery. But the fact is, that's nationwide. So if someone says, "Oh, you know, we're not going back to surgery. Every one of my surgeries comes out pristine," that's probably not the doctor that you want. And so that's where sometimes confidence can be overplayed. I do think it's good to have a surgeon who believes in themselves and confident, but someone who you can converse with is probably even more important. And someone who is willing to answer the questions that you want to ask. Some patients don't want to know like how high their risk is. I think sometimes it's hard, if patients ask us all the time, like, how long am I going to live? Well, our objective is for you to live a really long time. Now, if you look at the national average standard, it's X number of years. But recognize that that's a number that's like 20 years old and it's already changing. So, it's a hard question to answer. And so, there are questions that I believe patients can ask, like, what's the chance of my tumor coming back? Would you say it's a high risk or a low risk? And what does that mean to you, doctor? That's a better question, and something that if you're getting a direct answer from, that's important, and that's important for the relationship. But I just wanted to highlight that because I think patients use personality a lot because they're not experts. So what else you can judge by? People can judge personalities. So they're using that as a decision factor. I'm not saying it's unimportant, but even more important are what therapies does that doctor have at their fingertips to use in a personalized way for that particular cancer patient. That's what matters to me most.
Yeah, over the decades, the number of treatment choices has kind of exploded more recently, right? So there was a time like 20, 30 years ago where Yeah, personality would be really important because they're all going to give you the same drugs. And so it's kind of something about how they're going to do it. And that's thing. Now what we're saying is like personality can still be very important, but really kind of like different doctors have access to different things because of the way the clinical trial systems are set up. So that like that is a really big factor in the sense that they have something else to offer you. And then so personality is really important. But I think that, yeah, that's really interesting. So, um, all right, so I think that that's probably a good place to wrap up. I was wondering, Jason, could you kind of give a summary of kind of what would your advice to be, I guess, to break it into two, like one person who's kind of being faced with a surgical option and a choice, and one who is not, who is too advanced to have surgery, kind of what should they be thinking in those kind of moments of facing the diagnosis?
Right. And to me, just to summarize sort of what we talked about today, when diagnosed with cancer, it's going to be chaotic. Having family around or friends around, other people to listen, to pick up things and be able
Yeah.
to ask questions that you may not, because either you're too sick or you don't feel well or you're just in the world of chaos. All of those things are good reasons. But to try to get that together so that you can determine, number one, you know, is this a surgical emergency, right? I.e., an organ is going to be blocked. And if it doesn't make sense to you when they tell you the story about that, that that, then the answer is likely no, because again, the system will oftentimes sort of go a little, exaggerate a little bit on the urgency. If not urgent, then the question is, are you at the right place to get treatment for cancer, surgical or not? And the number two factor is get to an NCI accredited cancer center if you can. That may be as a second step if you had that surgical emergency. You gotta
Right.
take care of that, but then get to an NCI accredited cancer center. Number three is make sure that the doctor is doing a scan of the body to take a look for spread. And if there is, find out about, and no matter where, if there is or not, but especially in coordination with that, find out if you have a high risk cancer, meaning it will come back more than 20% of the time to us, or a low risk cancer, meaning the system is very likely to take care of this, never have to worry about this again. Once that's established, if it's low risk, just go with the flow, go with the standard of care at the NCI accredited center. You're going to get those results. If it's high risk, get a second opinion. And with that second opinion, you'll be able to then determine where are the gray zones, where are the things that there may be some variance in treatment or otherwise that could determine a difference to you. And ask, are there treatments for me before surgery, after surgery that could help to do better? Are there clinical trials or innovative approaches that could help me to do better that are personalized? Are there diagnostics that are specific that could open the door and understanding of what's driving that tumor so that we can attack it very personally and specifically? Those are, to me, the keys to helping patients succeed. And again, we do this day and day, in and out, all day long. And that's sort of, how we can best help patients, because this is all hard. And it's understood that that's the case. But that's how we could get started.
It's good. The only thing I'd add is we have a lot of patients who do their own research, and I think every cancer patient should do their own research. I understand that it can be difficult, but I kind of see when patients come to us and say, here's what I found. This is my understanding. Can you help me with this? And we often find data that's more recent or data that's more specific. And I think that there's so many different factors in this that I think that understanding kind of the nuance of it. So I think a lot of cancer doctors, oncologists, and surgeons are kind of they've got a job to do, and they understand that you're scared and you want to, and they want to help you, but they only have what they have, and they're going to probably not go into details. And I think there is so many other details to go in. And I see so many patients come through Sagely Health and just get the benefit of kind of having a fuller picture of things. So I'd say that that's one of the reasons to come to Sagely Health, but it's also a reason to go talk to other doctors to get a fuller picture of what's going on so that you can make informed choices. So yeah, I mean,
Yeah,
anything
I
else?
mean, it's hard. There's, again, as you mentioned, there's thousands of options, and for every oncologist, it's really hard to stay up on it. I mean, they're busy seeing patients, writing medicine scripts, and in checking labs, checking scans. We have the advantage that, again, our jobs are to stay up on top of all of the innovative medicines in cancer, and we're doing that day in and day out. And so that, and then we want to work with the patient and their doctors in order to get the best care. Sometimes it's right with the same doctor. Sometimes it requires going to a different doctor for some time and then back to the first doctor. Again, we're not in the game of playing favorite doctors. What we are is playing favorite treatments and making sure those treatments are aligned specifically for the patient and the tumor that they have.
All right. Well, I would say that's probably a good place to wrap up. I think this has been good. We'll get this up on the website. And yeah, if anyone has questions or wants to engage Sagely Health, we're here at sagelyhealth.com. And thank you for the time today, Jason.
Yeah. Thank you, and take care, everyone. Wish you all the best.